different lens. I think this is going to be a pretty interesting and thought-provoking presentation, which I hope you'll all enjoy and learn from. Just a little bit of etiquette and housekeeping. We have people dialing on as we speak, so just to alert folks that this session will be recorded. And to reduce distractions and background noise, we're going to go ahead and mute all of the attendees. And if by any chance, though, we do choose to unmute folks, please make sure that you don't put your phone on hold and make sure that you kind of silence your voicemail and ringers, etc. And that's just to keep it clean and helpful for the other listeners. Just a quick set of logistics and ways to engage you. If you have any logistic questions, if you're having difficulty, you can use the chat function, which should be the kind of second box down on the right side of your screen. You can, if you've got logistics questions or problems, you can chat to the host. If you have questions for the speakers, we ask that you use the chat function to all participants. That helps others see what questions are in the queue and also might prompt some of their own questions, which would be great. We can also have people raise their hands. You'll see under the first box, you'll see these little icons, which I can't really point to, but one of them is a little hand. If you've got good vision, you can click on that hand and it'll raise it, and I can unmute you to allow you to ask the question in person. You have to have, however, kind of had the system call you. I see already that we've got maybe a half dozen call-in user numbers, which means that your name is not really connected with a phone line, so I may not be able to unmute you. So it may be that chat's the easier way to go. You'll also see at the bottom of this a little polling place. And you're going to be hearing a lot about the PFCC program. And if you decide that you'd like to be a part of the mailing list for that program, you can go ahead and put your first and last name and your email address and hit the submit button. And that information will get forwarded to our speaker today, and you can be a part of his ongoing mailing list. So I have the privilege of introducing Dr. Anthony or Tony DeGioia. He is a practicing orthopedic surgeon and an engineer by training, so kind of a cool combination. He developed the patient and family-centered care methodology and practice, also known as PFCC, which is based on the third science for healthcare called design sciences and builds upon traditional clinical research and process improvement efforts. So this is kind of combining the design approaches that you've heard about from IDEO and some of the things that Kaiser's done, and marries them with a lot of the work that many of you are familiar with from the Institute for Healthcare Improvement, or IHI. The PFCC requires caregivers to view all care through the eyes of patients and their families, and really helps transform the delivery of care because care is designed for the end user. So we're talking a lot about patient experience, and this is really what this is all about. PFCC is an experience-based tool that co-designs services, interactions, processes, and environments by partnering with patients and families, as well as healthcare providers. So it's really a partnership here. This approach improves care delivery through a full cycle of care without the need for additional resources, underlined, and most importantly, develops the culture to achieve understanding outcomes, safety, quality, and waste reduction. The PFCC has been adopted by over 50 different care experiences at the University of Pittsburgh Medical Center with great success. Dr. DeGioia collaborates with caregivers and healthcare leaders to export the PFCC methodology and practice for any care experience and any organization, and is helping to develop a national PFCC community of practice. And that's why, if you're interested, it would be great to sign up under that polling space to be a part of his mailing list. He is board certified in orthopedic surgery and a fellow of the American Academy of Orthopedic Surgeons, as well as the American College of Surgeons, and is a faculty member for the Institute for Healthcare Improvement. He has received numerous professional awards, including the Pittsburgh History Makers Award in the area of medicine and health. And with that, I am going to pass the baton to Dr. DeGioia to allow him to give you his presentation.
Thank you, Sophia.
Can
we go back to that first slide, too?
You've got it, Tony. So you've got to kind of do that top arrow.
Yep, we're set.
Okay.
But thank you very much, Sophia. It's a nice opportunity to cross coast here and talk a little bit more about the methodology. Just some objectives, and Sophia had mentioned these already. First of all, to understand that we do need what we consider a new operating system for healthcare delivery. And the steps to do that are to view care through the eyes of patients and family, co-design, a process that I'll talk about, but also understand that we're not leaving behind all the process improvement tools that we've built up and used to deliver better care, but actually building on those successes. One question, and maybe this audience, we don't have to pose this question, but why change? And fitting with the theme, we just go back to our patients and families. And when you talk to them about our current healthcare delivery system, one of the things that comes through very strong is that we're not delivering the basics in a very, very complex system, and that we must begin to focus on providing this full cycle of care outside the walls of our hospitals and offices. And when you talk to them about real value, and value should be what we're focusing on delivering in the new healthcare delivery models, it's transitions of care and communications. So what we've learned from other industries outside healthcare is that no industry has survived without focusing on the needs and wants of their end users and delivering value. And in many ways in healthcare, we've lost those themes along the way. And it's very clear that we need to begin to listen to our patients and families as well as caregivers, because they're all our end users of the care delivery system. And in some ways, we need the fundamental change, not just the incremental changes. And that's where we feel that the PFCC methodology and practice is a simple grassroots approach that has a singular goal of delivering exceptional care experiences for patients and family by viewing all care through their eyes. And we think the PFCC approach provides the tools to transform care by really becoming the new operating system for healthcare. As Sophia mentioned, it is well grounded in the sciences, and I'm not going to talk a lot about that, but the area of design sciences and experience-based design is a very mature approach in other industries. So what that means for healthcare is that we need to design the services, interactions, processes, and environments for a complete experience, not just a service line, and most importantly, making it better for the end user and providing value, expanding on but not replacing clinical sciences and process improvement. And one of the most powerful parts of the methodology in the design sciences is focused on the implementation phase. You know, we all have been presented with best practices and best hospitals and best care delivery models, but what's missing over and over is can we go from our own current states or our own institutions to the ideal? And that's really where the strength is of the design sciences in PFCC. So there's three keys that we feel are necessary for our new operating system. First, and you've heard, and we'll come back to this over and over, view all care as an experience through the eyes of patients and families. Secondly, co-design. Now, co-design is not a term that we've used in healthcare, but it's actually a continuum that we are involved in. The most primitive version of co-design is where we listen to patients' complaints and we respond to those complaints. Hopefully then you get into listening and responding as well as being proactive and preventing problems. And then you get into the phase of consulting and advisory. And this is in the area, for instance, of patient and family advisory councils. But ultimately, the most mature version of co-design is where you partner with patients, families, and caregivers to actually design the models for care delivery. And the key number three, as I mentioned, is implementation. We need simple solutions for our complex system, and simple solutions that provides a reproducible methodology that can take you from your current state to the ideal experience understanding you need to co-design with patients, families, and caregivers, but also there are going to be hurdles, and you need to overcome those hurdles. And that's the roots, the basic root of the PFCC methodology in practice. So what that means, if you adopt this as our new operating system, is we have a singular goal of providing exceptional care experiences for patients and their families. And one of the important messages, we view patients and families as the unit. We never separate from families from patients, and I'll talk about that a little bit later on why, but it's very important. They are the care unit. They are the care unit. But it just so happens that we also can deliver the better outcomes, quality, safety, and reduce waste, which we wanted to do. Importantly for your leaders is you are just refocusing existing resources, and you do not need new ones to implement the new operating system. And very importantly for you is, as I mentioned, everyone's current state can be very different. So we aren't going to tell you the final answers, but we will provide you the tools so that you with your care teams will identify and solve and implement solutions in your own environment with the help of patients and families. And this gets into what we like to point out is process versus performance. And again, we have to acknowledge up front that we're building on the shoulders of giants in the efforts of process improvement and evidence-based medicine. We're not leaving those behind, but it is time that we need to wrap that effort with what we call the entire care experience. So that this will be especially important as the healthcare reform accelerates towards the umbrella of accountable care, because we do need a singular focus and a simple reproducible methodology, and that will change people and processes. And the way you change people's behavior is through performance improvement. So if you understand that process, that the resources to do this process already exist within your own organization. And what I'd like to do is quickly go through the 6 steps of the methodology with the understanding that this will be a very superficial discussion of the methodology, but Sophia mentioned we have lots of background resources that are free and available for you to download that you can dig deeper into each of the steps. A couple of definitions that are important, though, as we move into this is how do we define our care teams? How do we build our teams? So we use the term caregiver in a somewhat different way that's been used in healthcare in the past. A caregiver is any person within a care setting whose work touches the patient's or family's experience. And that's setting the stage that this is truly a team effort. And caregivers can include family members that are caregivers as well as the parking people, the people that work behind the scenes to support us. So it's well beyond the classic or the typical care provider definition. Now, touch points are important because we're going to eventually map out the patient's care flow experience. And touch points are key moments and places in any care setting where patient and family's care experiences are directly or indirectly affected by any caregiver. So step 1, define the care experience. And keep in mind that our goal is to go from your current state, which can be very different from city to city or place to place or care experience to the ideal experience. And in this process, through the methodology, you will develop unique care teams that will work together, sometimes for the first time, and develop solutions and test solutions. So an important step in the first part is to define your care experience. Now, care experiences can be very broad or they can be very narrow, and they can be from in a hospital to an office to an outpatient imaging center to a day of surgery center. The key thing is that you are going to define the beginning and the end of the care experience. So as an example, and we're going to be using some more outpatient examples for this webinar since that's much of your interest comes from that side. We have a Child and Family Services Behavioral Health Care Experience Working Group. Their care experience begins from the first phone call for intake for an appointment and ends once the patient leaves the facility after meeting with the therapist. Another example in an outpatient setting is the Diabetes Care Experience Working Group, where it begins with the first phone call for an office appointment and ends upon departure or a follow-up call by the staff with the patient regarding their test results. The key thing is that this sets the stage, though, for your focus. Now, you don't have to be afraid that the focus can evolve or change over time as well. So you can make it broader or more narrow as you get into the process. Typically, it goes broader because you find out that there's areas before your care experience and after your care experience that impact the care experience, so you need to build those into the process. The second step is to select your guiding council. Now, the guiding council you can think of is the nucleus and the strategic team that's going to set the stage for your full care experience working group. We recommend that you have an administrative champion, a clinical champion, and a PFCC coordinator. Administrative champion is someone that will help you overcome the hurdles and is at the right position within the organization. The clinical champion is someone that really knows the clinical side of the care experience the best. And the coordinator can be an administrative assistant or a practice manager, someone that helps keep the working group and the guiding council on schedule with information. Step number 3, determine your current state, view care through the eyes of patients and families, and develop a sense of urgency for change. And this is a critical step because the guiding council is now setting the stage for how to build your care team into the working group, but also to provide the feedback initially to the working group and forcing everyone to view care as an experience through the eyes of patients and families. A key PFCC app, as we say, is called Shadowing and Care Experience Flow Mapping. And we think these are the best 2 places to start and actually critical to implementing the methodology. Shadowing is where we actually walk the walks with patients and families through the selected care experience, in which you can record not only objective information but also subjective information. And it's a very, very high impact tool for the dollars and effort spent. Tim Brown, and he's actually from IDEO, in his book Change by Design, said it best: when we watch what people do and do not do, and listen to what they say and do not say, the easiest thing about the search for insight, in contrast to the search for hard data, is that it's everywhere and it's free. What shadowing allows you to do, though, is to develop the care experience flow map. The care experience flow map determines the caregivers and the touch points. And again, remember, we're setting the stage to develop these unique PFCC care teams. It also allows you to compare what is the perceived true care experience flow versus the assumed, and it determines your current state. One of the things we found when we asked the working groups if they can map out the patients and families' care experience for the care experience they were selected to represent, and we have yet to have a working group accurately map out the true flow of the patients and families through their own care experience. So it's a very important tool to use. One of the groups that's adopted PFCC in Nashville, in the Baptist system, is Susan said, "I can't tell you how impactful shadowing is, and once people shadow, they talk about PFCC very differently. Getting to view care through the eyes of patients and families truly provides caregivers with that different perspective." And remember, we're also would like to generate the sense of urgency to drive change. So the first steps towards the transformation is shadowing continually engages and partners with patients, families, and caregivers in the co-design process. Think of it as developing a real-time patient and family advisory council. And if you're not even interested in the PFCC methodology, I always recommend that you should shadow, because shadowing will show you where the needs are and where the opportunities are and generate that sense of urgency so that your caregivers will want to have a tool to drive change. So an example for step 3, this is the Diabetes Working Group Care Experience Flow Map. You can do this very, very simply in 2 columns. What are the touch points? What are the caregivers? As you map the flow. You can also, I'll go back, you can also do this a little more formally, in which you can actually do flow charts that also can give you visual information on where patients go and many times the inefficiencies of the flow of the patient. Step 4, now you're going to expand your guiding counsel to the full care experience working group through your touch points. So what you've done is you've mapped the flow of the patient and family through your care experience, and you have these touch points. So for instance, a simple example is many times parking is the first touch point for our patients and families as they come to our facilities. Parking has to be represented on your working group. So it's well beyond the traditional care providers. And taking that simple chart from before, you have your touch points, your caregivers, and remember these are generic names, but they're the functions that people perform. And then you create the team list. These are real people now that represent the caregivers and the touch points. And an important part of this is not and should not just be managers. This cuts across your whole organization at every level of the organization. And that's one of the unique parts that creates a very powerful engine on the care experience working group. What we do in the working group, the very first meeting that we have, the kickoff meeting, we call it for the full working group, we present the shadowing results, very first. Because again, remember, we want to begin to set the stage that from this point on, we all view care through the eyes of patients and families. One of the second things we do is the homework for the working group is to create what we call the shared vision for the ideal care experience. And surprisingly, this isn't as easy as it sounds sometimes, because all of us in healthcare have been sort of beat down on for so many years that our creativity has been somewhat suppressed. So we actually have sometimes a challenge in getting the working groups to sort of open up and to really think blue sky. Because when you write the story, first of all, the story has to be written as if I was the patient or family member. So it was I went to the emergency room with my mom who was complaining of shortness of breath, or I went to the same-day surgery for my elective surgery. And the entire story is written in that formation. You can do it many different ways. We do it collectively through the whole working group. We break it up into parts. We have patient and families that contribute to the ideal story as well. But it creates, number one, a brainstorming session, and it also opens up people's eyes that there are possibly things that we can do that we don't think about, because there's no regulatory, there's no financial, there's no organizational restrictions for writing the true story. And just to give you just a real quick example, this isn't a full story, but this is from the same-day surgery ideal story. So the need was patients were having problems scheduling their surgery and were receiving incorrect orders. Getting in touch with specialist office was especially difficult. The ideal: from the moment I found I needed surgery, I was placed in the tender care of a same-day surgery representative that acted as my concierge for the whole process. She answered our questions, coordinated our appointments, and was really a one-stop shop for us with regard to my surgery. It was so much easier having one all-encompassing go-to person instead of having to coordinate everything myself with multiple departments and individuals. She knew me, my family, and my case. And as you can probably ascertain, this is now setting the stage for the ideal. So we've determined your current state, we started to build your team, and now we're setting the stage for what is the ideal care experience from the patients and families. And that gets to step 6. So step 6 is a microcosm of your working group. What you do, what you will find out, you will have so many opportunities that are identified for improvement, you just can't tackle them all at the same time. So what we recommend is you develop anywhere between 3 to 6 PFCC project improvement teams that follow the same 6 steps of the methodology, and this is where the work really gets done. One of the nice things with the methodology is it's a self-learning, self-reinforcing methodology, because those same 6 steps that I discussed in developing your PFCC working group are the same 6 steps that the project team uses as well. Select the care experience, develop your co-leaders, evaluate your current state, PFCC teams based on the touch points, develop a shared vision and ideal, and develop improvement projects. And remember, this is a microcosm, so the segment that you pick can be very narrow within your bigger care experience. As an example, on one of our broadest care experiences is a level 1 trauma care experience. And the level 1 trauma care experience began from the time they get their first call in the field about a patient to the time that patient's discharged from the hospital and everything in between. And you can imagine the opportunities for improvement through that. But what they've done is over time they've gone from use this process and have project teams that focus on shorter segments within that to solve the problem. We like to have people think about the PFCC care experience working groups are forever. Because remember, you can never achieve the ideals. The ideal is always pushed up higher. You will achieve the ideal that you have set out, especially even in your ideal stories, but you push it out even further. Project teams, on the other hand, can live and die. They're like little tornadoes that create change within the organization. And once they finish their project, they can go away, and then it's remixed to go on to the next project. One of the important parts of the methodology, too, especially I think for people that have been involved in process improvement, is we do not leave metrics behind. And if, in fact, I recently came back from a policy conference in D.C. that there's really 4 buckets of information that we're going to be required to collect as part of the umbrella of accountable care. There's the clinical outcomes, quality, and safety. There's patient-reported outcomes with shared decision-making. There's patient and family care experiences, for instance, through the HCAPs, and also true costs, not just charges. And when you think about it, the only common denominator around all 4 of these buckets is the patient and family. So while we focus on patient and family's care experience, we can begin to collect all this information that will allow us to compete in the new world. As I mentioned up front, the methodology also has to address that there will be challenges. And PFCC and patient and family-centered care itself, in many ways, is disruptive or transformational to our organizations. And that has unique challenges to it. So as Dawn Berwick said, delivering these great care experiences is really simple. The complexity is largely a reflection of the environment in which we find ourselves, and probably no more so than now. So when you focus on this, you have to understand that there will be disruptions. And there's a couple books. If you ever read Clayton Christensen's Innovator's Dilemma, which is his very first book on transformation or disruptive technologies and processes, he talks about tools that we can use to overcome that. And that's what the methodology does. It crosses these silos within our organization. So for instance, for many of us that do surgery, we have our physician office and our acute hospital stay. Within those, there's many, many silos. But this is actually the flow of one of my patients that needs a total joint replacement. That's the full cycle of care. And what you're doing is, through the process, through the methodology, you're developing these care experience working groups that cut wide swaths across your organization and across these silos from top to bottom and side to side. And remember, the only common denominator in all care delivery is really our patient and families. So a couple questions. This is for people just to think about. And you don't have to vote, although if you want to raise your hand, that's okay. First question for the group is, think about how many in the audience have, in the last 6 months, have been a patient or a family member themselves, just in the last 6 months. Typically, in our audiences of caregivers, that's usually about 90 to 95%. Now, the second question, the follow-up question, though, is how many of you felt that it was the ideal care experience? And if it wasn't the ideal experience, how many of you came away with ideas on how to change the care experience? And the final question is, how many of you were really able to implement change? And usually that's very, very, very few people, unfortunately. But one of the most important themes of this is the untapped co-design resource is actually us. As caregivers, we're also family members and patients ourselves, but we separate ourselves from our care experiences as we become caregivers. So what this means, though, is that everything that we need is really within our organizations themselves. And with the help of other patients and family members, we can even take it further. Just a quick aside, we've developed our Bone and Joint Center at McGee actually was based in the PFCC methodology and practice. It's a become a very high volume center. McGee never had any orthopedics at all until about 5 years ago when we came here, and we've become one of the highest volume centers, and only with 3 full-time surgeons and only using 2 operating rooms a day. And all the metrics that we've used, and we do collect all the metrics on outcomes and safety and transfusion rates and infection rates, we're the highest levels in Western Pennsylvania, best levels in Western Pennsylvania with the most efficient OR. We have the lowest cost per case in Western Pennsylvania, and that's real cost because we track real cost, not charges, following the patient. And we certainly have developed some high-performing care teams. As Sophia mentioned, this has been a process evolving over the last 5 years at UPMC. It expanded initially just from the orthopedic program to now there's over 50 different active care experience working groups of all kinds at 8 different hospitals, from the biggest tertiary care hospital to the smallest community hospital. And we have, of that, many, many active project teams and completed projects within those groups. And we hope that continues to grow. These are just a sample of the other care experiences. And again, it can be for any facility or any care experience: bariatrics, women's health care, gyne-onc, home health, pediatrics. So it can be applied to any care experience. Just to give you a brief example of some other completed projects within the outpatient experience: diabetes care experience, develop patient folders, folder holders they're called, provide patients with organize their paperwork they receive. A simple thing, spill-proof specimen jars were piloted. An example of this is it was developed within a project team, expanded through the working group, the diabetes group, was found to be successful, and actually was operationalized throughout UPMC hospitals as far as spread. Pediatric rheumatology outpatient care experience: phone tree reorganization, pain-free blood draws, walking directions to offices from all entrances. Pediatric ENT care experience: distraction items added to exam rooms, a universal brochure created to streamline communications, improvements in press gaining. Bariatrics care experiences: behavioralists added to follow-up care, exercise classes for people not accustomed to exercise, and cooking classes with guest chefs to introduce new foods and healthier cooking methods. And just as a resource, we have on our website, and for those who would like to sign up, we have a list of our PFCC annual report from 2011 that includes all the care experiences and all the completed projects for those care experiences throughout UPMC. So it's a resource that you can use to go back to and see maybe there's some ideas that you can jumpstart some of your own care experiences. The things we've heard from our champions as they've gone through this is it's really, the PFCC operating system really is a grassroots and a pragmatic science because it's customized for healthcare, and it really gets us back to the focus of why we're in healthcare. The focus for change just so happens to be our mission, which is taking care of patients and their families. It's very simple to learn and build care teams. You don't have to go away to do a course. There's learning opportunities, both webinars to do this. It spreads through a grassroots methods. It generates a sense of urgency that helps you break down the silos. And ultimately, the whole goal of the methodology is to change the culture. So as we think about this new operating system, it's really the tools that you can use to drive this change in care delivery, because you, your care teams, patients, and families will determine the opportunities for improvement, propose and test these solutions, implement them and test the implementation, and then if they do work, you will be able to operationalize them. And this is how you change the behavior of people and change the culture. The community is growing outside Western Pennsylvania. A month ago, I was asked to do a keynote down in Memphis, and this group had attended one of the IHI's live case visits and learned the methodology and went back home and got to work. And in about a year and a half, they have three of their 6 hospitals have adopted the PFCC methodology and using it. These are some of the other partners that are in different stages of adopting the methodology, but we do think that it's a tool that you can use or anyone can use in their own environments. So it's really up to you and up to us as caregivers as well as patients and families. We need a catalyst, and maybe this can be the catalyst for change. So what we'd like to do is show you a little bit, have a little fun, but how do you start a PFCC movement? And that's one of our goals. As Sophia mentioned, we may call it a community of practice, but really it's a PFCC movement. So I'll turn that back over. You want to, there we go. Turn up your volumes if you have them turned down.
Ladies and gentlemen, at TED we talk a lot about leadership and how to make a movement. So let's watch a movement happen start to finish in under 3 minutes and dissect some lessons from it. First, of course, you know, a leader needs the guts to stand out and be ridiculed. But what he's doing is so easy to follow. So here's the first follower with a crucial role. He's going to show everyone else how to follow. Now notice that the leader embraces him as an equal. So now it's not about the leader anymore. It's about them, plural. There he is calling to his friends. Now if you notice that the first follower is actually an underestimated form of leadership in itself. It takes guts to stand out like that. The first follower is what transforms a lone nut into a leader. Second follower. Now it's not a lone nut, it's not 2 nuts, 3 is a crowd, and the crowd is news. So a movement must be public. It's important to show not just the leader, but the followers, because you find that new followers emulate the followers, not the leader. Now here come 2 more people, and immediately after, 3 more people. Now we've got momentum. This is the tipping point. Now we've got a movement. So notice that as more people join in, it's less risky. So those that were sitting on the fence before now have no reason not to. They won't stand out, they won't be ridiculed, but they will be part of the in crowd if they hurry. So over the next minute, you'll see all of the those that prefer to stick with the crowd, because eventually they would be ridiculed for not joining in. And that's how you make a movement. But let's recap some lessons from this. So first, if you are the type, like the shirtless dancing guy, that is standing alone, remember the importance of nurturing your first few followers as equals. So it's clearly about the movement, not you. Okay, but we might have missed the real lesson here. The biggest lesson, if you noticed, did you catch it? Is that leadership is over-glorified. That yes, it was the shirtless guy was first, and he'll get all the credit, but it was really the first follower that transformed the lone nut into a leader. So as we're told that we should all be leaders, that would be really ineffective. If you really care about starting a movement, have the courage to follow and show others how to follow. And when you find a lone nut doing something great, have the guts to be the first one to stand up and join in. And what a perfect place to do that, to TED. Thanks.
The real question is, we think that you can be both the lone nut and the first follower, and that has to be built into the methodology, because all of us undertake some projects that really push the limit, but as you heard, really developing the first followers or being the first followers is the next steps. And that's built into the methodology as well, because embedded in this is a new set of behaviors that converts followers to self-directing leaders. Caregivers can develop a new sense of self-identity because they will take ownership of potentially the historic events that happen in healthcare. And since it's a very, very grassroots effort, that's the way you build the movement. So the PFCC, as the new operating system, We know that you can go from your current to the ideal. We've had enough experience now to be confident that we can give you the tools to get there. So a couple of resources to keep in mind beyond the webinar is every year, twice a year, we run what's called a PFCC Vision Quest. We just had our last one in June 1st here in Pittsburgh, and we had over 150 participants, and over 50% of the participants were from outside Western Pennsylvania. In addition, we are running webinar series. For instance, after the Vision Quest, we have 2 free webinars that are open to the public, even if you didn't attend the Vision Quest, that focus on steps 1 through 3 and then steps 4 through 6. So these are additional learning opportunities that are open to you if you'd like to participate in the site for more information is presented. But in closing, before taking on questions, we really do think we need a new operating system. And the operating system that's posed by PFCC not only returns us to the focus of why we're in healthcare, but it is the focus that will drive change as well. And only by engaging patients and families as partners in this process will we really be able to achieve what we all want to achieve, which is accountable care for patients and families. So with that, I'd like to thank you. And if you can take any questions, I think Sophia is going to act as a moderator.
Yeah, so please, if you have any questions, go ahead and put them in the chat box and send it to all participants. But I'm going to actually lead off, Tony, with the question, which is, can you give maybe a little bit more of a concrete example? You gave some examples earlier, but of what were the kinds of problems that have helped the teams figure out they need to use your methodology? Was it, what was it that took them to either, do the shadowing, or can you give some examples of how to actually get this started? Because I think that's one of the more difficult things for people who haven't used the method.
I think far and away the most important first step is to shadow. And again, even if you're not interested in the methodology, the shadowing is so impactful both in the information you collect, but also on the shadower's experience. And for instance, we have now recommended that caregivers are the ones that do all the shadowing. And one of our groups, even in the same-day surgery, she set up a program where every new hire in her department was shadowed before they assume their set role as part of the team. Because it collects information, but it has the flip side of it that maybe is an unexpected positive consequence is it changes the way caregivers do their job as well. So even if you're not interested in the methodology, I would suggest you set up a shadowing, and it's shadowing you can learn in 20 to 30 minutes. We have go guides to support the shadowing, both the training and the information collection. So I would say you should just shadow the care experience, and it begins that process of viewing care through the eyes of patients and families, and it will show you very, very clearly the opportunities for change. Shadowing also opens up eyes because it forces even us to look outside the silo of where we work. So, for instance, in my office, that's one silo, but how many people really know the details of what it took for a patient to start that journey from home, both the first call, but the physical journey as well, all the way into the practice and the information they're given and asked to fill out and those kind of things. And once you begin that process, you can also start designing the system that sets the stage to make you more efficient in handling patients as well. So shadowing, no doubt, is the place to start.
And I guess then, once you've started to get some of these teams up and running, can you tell us a little bit more frankly what some of the barriers or enablers were across the UPMC system?
So initially, as I mentioned, you do have to understand that although the organization thinks we take care of patients and families, We really don't. And when you present that to them, sometimes they get a little defensive. So one of the things that we try to emphasize is that this isn't to remove the defensiveness from that situation. It's not me as a doctor telling my administrator that we're not delivering ideal care experience with patients and families. It's the patient and the family members telling us that we're not delivering those care experiences. And one of the, again, unintended positive consequences of viewing care through the eyes of patients and families is it does remove a defensiveness that's in our organization that it's your fault, it's my fault, it's whose fault. There's no one at fault. It's the patient and family telling us this is the issues and this is what we need to improve upon. And we found in the working groups, when you do that, it lifts this defensiveness, and all of a sudden it does permit people to work together that maybe have not worked so well together before. Another key thing when you first start out in this effort is understanding it's a disruptive process. It is important to have upper-level support for your effort. So the way I describe that is that it's the CEO, the COO, the VP, and they don't have to be flag-waving supporters of PFCC, but you will, again, understand there's going to be hurdles that you're going to have to overcome. So you want to have their support and their understanding that they will be able to, they will assist you in helping to overcome those hurdles. And that was a big piece when we first started out, and until we created sort of the unique care experience teams. And now, for instance, the level 1 trauma care experience, we have the VP of Ops that is part of that working group all the way down to the parking guy and everyone in between. So it is going to bring together people, but with the understanding there are these unique challenges too. You don't, I think the power of the methodology is you don't have to worry about all that in the sense it's all in the background, and if you follow the steps through, the tools are there to help you overcome all those hurdles. Knowing they're going to be there, but if you follow the steps through, you will overcome those hurdles.
Someone asked a good question, which is, when you're shadowing patients, how do you prevent that, the whole kind of effect of being observed? How do you prevent the shadowing itself from influencing staff behavior?
Very good question. That's one of 2 questions we always get asked, and that's called the Hawthorne effect. Mm-hmm. So first of all, shadowing is not a secret shopper program. It's very open, and if anything, the shadower becomes part of the patient and family unit, and it's okay if they add a positive part of the shadowing experience. There's a balance between being an unobjective observer, which is important, but there's also a balance where our shadowers actually have assisted patients through the care experience as well. And certainly if there's any safety issues and things like that, there's no doubt that people step in right away. As an example of this effect is we received a grant from Picker called the Guardian Angel program. And the story behind that was that we kicked off the inpatient transplant care experience at Presbyterian University Hospital about 1.5 years ago, and we were shadowing patients as they came in to receive their transplants. And as you can imagine, a high-stress care experience, this is one of the highest stress. And it just so happened it was actually a child that was coming in for a lung transplant with his mom. And they came in the middle of the night, everything's closed, none of the resources are available that are typically available in the daytime. And our shadower met them there for their care experience and followed that family through their care experience. And unfortunately, they were not able to get the transplant on that time. They did subsequently in another visit, but they had to go home. And the mother of the patient turned to our shadower and said, "You've been my guardian angel through this experience." Well, the Care Experience Working Group, the Transplant Care Experience Working Group, took that concept and they set up a pilot project where shadowers became guardian angels. And we just learned last week that they received a grant now that they have operationalized the Guardian Angel shadowing program so that every single transplant patient that comes through Presby 24/7 will be assigned a Guardian Angel. So we view it as a positive contribution. It's not to be viewed as interfering. There's so much information that you're going to be collecting that you don't have to worry about skewing the data, which is the science, right, the scientist in all of us.
Mm-hmm.
I'll address the second question that's most common, and it also is because of the scientist in us. People always ask, how many times do I have to shadow to be significant, right? That's a typical healthcare provider question.
Uh-huh.
And it's the scientist coming out in all of this, and that's fine. But what have we found? There's no set amount. But what happens, even after 1 or 2 or 3 shadowing, there are such strong themes of opportunities that come clearly visible that you don't have to do 10 of them to do it, to identify those. On the flip side of this, too, remember that shadowing is not a one-time tool. Shadowing is part of the methodology that's done over and over and over again. So you're going to be re-shadowing. Even care experiences that you change, you're going to be re-shadowing. So it's this repetitive observation that becomes very powerful. So you don't have to think about it in a quantitative matter that you have to do 5 shadowing to be significant. It's this repetitive nature of it and the power of the shadowing process itself that becomes important.
So Tony, how do you measure success? Because you mentioned that as part of the, it's okay to have the shadow actually be a guardian angel, but, you had mentioned those 4 domains in that earlier slide. So you have the potential for collecting all 4 of those metrics. Not all our groups collects all 4 of those metrics yet. I will say in orthopedics we collect all 4 of those metrics, and I think it does create a very powerful story, complete story. But you don't have to begin by collecting all 4 of those metrics. So say on one side of that chart, looking at care experiences, we have PFCC groups that have targeted and focused on the parts of the care experience that affect HCAHPS scores. So HCAHPS was used as one metric to look at the improvement for that, maybe not so much just HCAHPS, but the interaction that created with patients and families and how they're doing for improving HCAHPS over the long run. We have groups that, through project improvement, just look at the traditional clinical outcomes and safety. On the side of cost, we are looking at ways to build into the methodology ways to collect real cost for any care experience, so anyone could do that as well. So I don't want to have people feel overwhelmed that they have to collect all 4 of those buckets, but you have the opportunity to select the area that you'd like to focus in to begin with, but with the idea you're setting up the infrastructure to be able to collect all those buckets of information as well. I hope people aren't getting dizzy. I just asked Canel to try to go back to that domain slide. Keep going. Do you remember where it was? There. One forward. Yeah. Some of the metrics. Which ones? I mean, it seems like some of these may be easier to start with. Do you have a sense of which ones?
Well, I think if you come from a strong process improvement background, I think you look at the top bucket first because a lot of those could be more traditional outcomes measures. And then I think if you move towards the patient and family care experiences, another example we use is we believe in using a lot of informal surveys that are really quick, easy, collect a lot of information, and gives that information back to the working group to act on very quickly. And we actually have a library of those surveys on our website that people can use for all different care experiences. Mm-hmm. So I think if you were going to start, it would be more in the clinical outcomes, quality, safety, and patient and family care experiences. We are looking at different tools to use for patient-reported outcomes. So that's something being developed, and as I mentioned, we're working with the Harvard Business School on a methodology that they've developed that we can use as part of the methodology to collect true costs for delivering any care experience.
That's helpful. I mean, I think people often really get stuck on how do you actually, how do you actually measure the impact. So here's another question, which is by shadowing, were you able to identify the cultural and linguistic needs of your patients?
Good question again. The answer is yes. I will say in Pittsburgh that's less of an issue. Cultural, yes. Linguistic, not so much. But again, if you're a shadower as part of the patient and family unit and you are able to firsthand see, for instance, difficulties in communications, that'll be a need that's identified very, very quickly through the shadowing process. Or if there's cultural differences, the conference I was just at in DC on Friday at an IHI event, and the issue with the gay and lesbian community came up, and identifying the needs for that specific community moving ahead. And absolutely, you'd be able to identify needs that are for these different groups. I will say that I am always a little reluctant to create other silos, though, too, because as they come through, everyone's a patient or a family member of a patient, and there's sort of the basic needs that you need to provide. And I think what shadowing with the methodology will be able to address the needs of those patients and families, regardless of where you're coming from culturally or linguistically, but you will be able to identify opportunities for improvement.
Great. Any other questions? Canel, can you pass me the presenter ball, please? So I just want to remind folks on the, yes, someone asked if we can get copies of the slides. We will be posting a PDF of these slides along with the recording of the presentation on our website. And that is at www.chcf.org/CIN. And just a reminder again that if you want to continue to receive additional materials from Dr. DeGioia's group, put your name, first and last name in and your email address in that polling box and send that to us, and we will forward that information to his team so that you can become a part of his regular communication. But the other thing to also keep in mind is that they've also been kind enough to set up a separate website, which is this www.pfcc.org CIN webinar, where they have posted all of these materials that are available to all of us for free, which we really appreciate. And so, we've had so many conversations about how do we really improve the patient experience. And I think what this whole methodology and approach really does is to get us out of our provider hat and really put us in the shoes of patients and families. Because if we really want to improve the experience, it's not from our perspective, it's really got to be from theirs. And so it's just a huge opportunity to take some simple tools, put them to use, and really start to see and think about the experience in a different way. And I think what I particularly love about Dr. DeGioia's approach is, this is not a big, complicated project. These are things that you can start with in a very simple way. And I think a lot of times just really experiencing this starts to spark all of those positive ideas of the things that we can do rather than then get too stuck in how busy our day is and how hard things are to change. So I really urge folks to take a look at the materials and to kind of roll up your sleeves and try some of these approaches. And Dr. DeGioia, I really, really want to thank you for taking the time to present to us here in California and share the fabulous work that you've been doing.
Well, thank you very much. And like I said, it's all part of what we think should be the PFCC movement, that everyone could participate. So just remember that video. You may think you're the lone nut out there to begin with, but developing those followers really will make a huge difference in your own environments and definitely for patients and families.
Great. Thank you again, and thank you everyone for participating in our call today. Our next call actually will be next month. It will be the third Wednesday of the month instead of the fourth, and that will be a conversation with Dr. Ed Wagner about the range of patient-centered medical home activities that are going on across the country, some of which California programs, clinics are involved in, others of which we're not. So it's a chance for us here in California to learn about some of the activities and successes that are happening across the country. So have a wonderful rest of the day. Happy end of July and end of June and happy July 4th to all. Thank you.
Thanks, Sophia. Bye, everyone.
Bye-bye.